Blog Talk Radio. Welcome to Medicaid Matters, the only live talk show about the business of Medicaid health care. And now, here's the host of Medicaid Matters, Richard Yaden.
Well, hello everyone. Today is Tuesday, May 15th, 2012, and this is the Medicaid Matters Talk Show. I'm Richard Yaden, President and CEO of Managed Medicaid Services, and your host for the next hour. Today's show is about innovation, specifically award-winning innovation. And in just a few minutes, we'll be talking with Dr. Harvindeer Sareen from WellPoint. Dr. Sareen leads WellPoint state-sponsored businesses' Childhood Obesity Initiative. And if you were at the Medicaid Health Plans of America's Best Practice Awards program this past month, then you know this initiative won their Innovation Award. We did a live broadcast from that event, so you can watch that at the MedicaidTalk.com webpage, and we had a chance to speak with several of the other award winners as well. Well, as our regular listeners and our regular viewers know, you are tuning in today along with several hundred other Medicaid professionals. Like you, they know this is where they go. This is the place to be for the latest insights about what is happening in Medicaid today. And you can get more information about our show at MedicaidTalk.com. We are hearing that our show is becoming part of company staff meetings, departmental meetings, corporate training sessions, and a growing download is coming to us, or we're seeing a growing download of archive shows on iTunes. So make sure you invite a colleague to be a part of the Medicaid Talk community and participate in the show if they're not already joining in. Well, we are live, and we like for our listeners and for our viewers to call in and express their comments and thoughts about any topic that we're discussing on the show. There are a number of ways that you can participate in the show. The best way is just to call and talk to us. It's 626-657-2125. That's 626-657-2125. We'll take calls throughout the show today. You can join me here on the air with your comments or your opinions and your insights. You can ask them of me or discuss it with our guest, whatever makes sense for you. You can also connect with us on Twitter. We often get questions from our viewers and our listeners on Twitter, and our Twitter handle is at MedicaidTalk.com, or just at MedicaidTalk. I guess you don't need the .com on Twitter anymore. And also, if you're connected to us on Skype, we do take occasionally some instant messages from our viewers and listeners on Skype. And again, our Skype handle is Medicaid Talk. If you're not connected, go ahead and send us an invite. You can connect while we're on the air today and can take those questions and comments. You know, our show tries to get Medicaid innovations out in front and deliver them to you straight from the source. And today is special in that we're going to learn about a Medicaid innovation that is an award-winning initiative. On April 30th, the Medicaid Health Plans Centers for Best Practices awarded WellPoint state-sponsored businesses' Childhood Obesity Initiative its prestigious Innovation Award. Now, there were 17 different programs and initiatives nominated for this award, and a blue ribbon selection committee evaluated every single one of them. Now, that's not an easy task when you consider this award is given to the overall best practice in Medicaid health plans in the industry for the past year. Now, I'm not going to give away a lot of the details to you because we have the leader of this initiative on our show today, Dr. Harvindeer Sareen. If you're not familiar with Dr. Sareen, Dr. Sareen plays a key role in leading WellPoint's initiative to promote healthier lifestyles and to address childhood obesity. Her work focuses on leveraging clinical best practices, instituting functional health literacy to improve health outcomes, advancing patient-centered medical homes in Medicaid, and evaluating innovative approaches such as exergaming for health promotion. First time I've heard that word, and hopefully Dr. Sareen can elaborate on that some. She's also spearheaded several collaborative projects with leaders in the arenas of healthcare and in research and public service, including the National Committee for Quality Assurance, to pilot test the feasibility of a performance measure in childhood obesity. Also, the Centers of Disease Control and Prevention and the California Child Health and Disability Prevention Program to promote standard screening for obesity and BMI measurement. The California Governor's Council on Physical Fitness and Sports to promote healthier lifestyles among young adolescents in low-income communities, and the University of California, Los Angeles to evaluate the effectiveness of fresh fruit and vegetable bar programs in Los Angeles Unified School District. In addition to all that, Dr. Sareen has developed Simple Steps, a pilot wellness program for employees under the umbrella of WellPoint's Choose Better Health program. She also co-chaired the California WellPoint Association Wellness Committee for 5 years. Dr. Sareen holds a doctoral degree from the UCLA School of Public Health with a minor in anthropology. Her previous work includes working closely with the underserved populations in northern India, the Women, Infants, and Children program in South Los Angeles, the California Healthy Start program, AIDS Project Los Angeles, First Five Ventura County, California, and the American Academy of Pediatrics. Well, Dr. Sareen, welcome to today's show.
Thank you, Richard. It's a pleasure to join you and your listeners today.
Well, we're certainly happy to have you here. I think this is going to be a very interesting discussion for our listeners because, there's no question that childhood obesity is a problem across the country, not just in Medicaid, but I know it's very much focused in Medicaid, and in our conversations with others, certainly has been a priority for them. Why don't you share with our audience just a little bit about how you became involved in Medicaid healthcare?
Sure. I would say I've been involved for many years. About 7 years ago, WellPoint Medicaid, state-sponsored business, or Medicaid, was on the lookout for someone to define and lead a very innovative initiative around childhood obesity. I was at UCLA at that time, and given my background and my passion for this topic, it just was a great fit. And that was my entry into Medicaid managed care, healthcare, and I've been excited to be a part of the team ever since.
Well, great, and it sounds like you are off to a running start based on that background and that bio. So what is exactly the scope of your role at WellPoint?
Well, as you can imagine, my work primarily focuses on obesity programs, but however, I also spearhead a number of key innovative pilots or programs that range from clinical interventions, payment innovation, revenue enhancement, and a few examples would be patient-centered medical homes for high-risk OB women or Medicaid risk adjustment. And I also serve as a consultant to the WellPoint Foundation on a number of projects.
Does your work with the patient-centered medical homes, I know that's a big topic for our audience, or certainly an important topic for our audience as well, does that intersect in any way with the work you're doing in childhood obesity?
In a way, yes. I mean, if you take into account the life course perspective and the fact that, you need to focus on all aspects, not just, when the child is born, but just really starting, even in the prenatal phase, certainly. So the patient-centered medical home is focused on prenatal care and ensuring that, especially the high-risk women get appropriate and timely prenatal care.
Mm-hmm. Now, a lot of the work that you're doing, both in this initiative and outside of WellPoint, is very focused around promoting healthier lifestyles. Is that something that you've always been involved with, or has that just been something that you've become more involved with as a part of your work at WellPoint?
I've always had a passion for promoting healthier lifestyle, and my training, as you've already mentioned, is in that area. I was a dietitian in my past life. But I think, just joining WellPoint and then looking at the problem at hand, looking at the scope, looking at what's needed, I think I would say I've become more and more involved in what we phrased as Childhood Obesity Initiative, but what we're phrasing now more and more as promoting healthier lifestyles.
Mm-hmm. Well, it's important, and we've had guests on our show before, and I know our viewers and listeners know that I'm a very strong advocate that the core of the solutions to many of our issues in healthcare today, not just in Medicaid but across the country, is lifestyle issues and people taking more responsibility for those things. I know it's easier said than done, but certainly it's got to be a part of what every health plan is doing today. Wouldn't you agree?
I would say so, yes.
Good. Well, a few weeks ago, I was there with you in Washington at the U.S. Chamber of Commerce where the awards function was taking place. You accepted an award from the Medicaid Health Plans of America's Best Practices, or Center for Best Practices. So tell us a little bit about that award, and then we'll get into the program after that.
Sure. I have to say we were so excited. I think it was so exciting and reinforcing for us to receive that recognition. We were the recipients of the 2011-2012 Innovation Award from the MHPA Center of Best Practices, and we received that award for promoting healthier lifestyles, which is, our initiative to address childhood obesity. So it was really high recognition from the MHPA Center of Best Practices.
And there was some stiff competition for that award too, wasn't there?
There was, yes.
So it's quite an honor to do that. And this isn't the first award you've received from MHPA, is it?
That is right. We've received we've received numerous awards and recognition, but this is probably the first Medicaid award that we've received. So it certainly has a special place of its own.
Yes, no doubt. Well, there are a lot of issues today in Medicaid that our viewers and our listeners are working through. Childhood obesity is certainly on everyone's radar today. What was happening at WellPoint that led you to start focusing on this particular initiative?
Well, this initiative, we began way back, so as early as 2005. And what we noticed was there was a increase in prevalence. So there was an increase in childhood obesity. We were noticing that more and more of our pediatric Medicaid members were not at a healthy weight. There were also cases of type 2 diabetes that began trickling in among our pediatric patients. The other thing we noticed was that solutions were scarce, and by that I mean it seemed like our physicians were struggling. They were not sure about how to address this issue. They were not using body mass index. They seemed to be, uncomfortable in engaging and interacting with their families to address childhood obesity. So I think that really put the onus on developing this initiative to address childhood obesity. And, honestly, at a personal level, I think all of us, many of us are working parents, and we realized that this was a huge epidemic, and we could appreciate the challenges that, a number of parents have to deal with in terms of balancing, work and home and ensuring that our children really have a healthy lifestyle.
This is a problem that we're hearing a lot of press about across the board. And it's something that I think, all segments of the population are dealing with. How is it different in the Medicaid population?
Well, the prevalence is higher because we know that low-income families tend to have a higher prevalence of childhood obesity. I think there are estimates that indicate that 1 in 3 low-income children are either overweight or obese before their 5th birthday.
Wow.
And within that, minorities are particularly at risk. So that would mean that especially Hispanic and African American families are definitely disproportionately at risk.
Wow. Well, I can see that it needs to be moved to the top of the list, no question about it. Well, we're going to stop here for just a few minutes and hear a few messages from our sponsors. When we come back, we're going to talk more about the details of this initiative. So stay with us.
Sure.
Elevating the quality of care with less cost.
Today, that's the job of every Medicaid managed care company, but it can't be business as usual. Companies have to coordinate care a different way. The solution is managed Medicaid services. Through our virtual case manager network, our teams of Medicaid assessment specialists, and our new Advanced Care Transitions program, companies can dramatically raise the quality of care without increasing their costs. Visit us today at MedicaidServices.net. Managed Medicaid Services, your best source for innovative care management.
The Medicaid landscape is changing fast, and that means challenges. But it also means opportunity. Opportunity for you. And that's why you need to visit MedicaidJobs.net. MedicaidJobs.net is the place to showcase your talent to Medicaid companies, search for jobs, research the latest career trends, and register for the free Career Optimizer service. Don't wait. Go to MedicaidJobs.net today.
And welcome back to Medicaid Matters. This is the only live and interactive talk show about the business of Medicaid health care. If you've not been to MedicaidJobs.net, then you might be missing an opportunity to accelerate the next step in your career. I know our firm places almost all of our searches there, and we are seeing a big uptick in the search for Medicaid talent. If you don't see what you're looking for, give us a call at 866-371-0687, extension 210, and one of our search consultants will be in touch right away. Today we're talking with Dr. Harvindeer Sareen, Director of Clinical Programs at WellPoint State-Sponsored Business. Dr. Sareen heads the Childhood Obesity Initiative. Well, Dr. Sareen, without going into exhaustive detail, but I know our listeners are really interested in hearing about this. Without going into too much details, tell us about this initiative kind of as a whole and how it works.
Sure. And so, as I mentioned, it's really a multifaceted initiative. It's a compilation of programs, if you will. Mm-hmm. And what it does is it really has an integrated kind of a primary care public health approach to address childhood obesity. So by that I mean that it includes a slew of provider, member, and community-based efforts. I think when we started out, Richard, it was really clear to us that multiple solutions were needed for positive outcomes around childhood obesity, and we realized that some of those solutions would be, very consistent with our traditional role, and some of those solutions would not, and which is why we really focused on adding a very comprehensive collection of efforts.
How many different, and I'll just use this word because it might be descriptive for our audience, how many different programs are involved in this initiative?
That's a difficult question to answer. I can just say that there are numerous programs focused on supporting our primary care, numerous programs that are research-based on enhancing the evidence-based, reaching out to our members. We're focused on modifying the children's environment, which means we're out in the community, we're out in schools, trying to make a change out there. We leverage public-private partnerships, collaborations, and we've had great partners that we've worked with over the years, and we really focus on innovation.
Yeah, well, and that's probably why you got the award.
We did.
Yeah. What was going on in WellPoint or within your Medicaid patient population that drove childhood obesity to such a high level of priority? In other words, what problem had to be solved in order to create this initiative, or drove the process of creating this initiative?
Well, childhood obesity is a priority, and as I mentioned, we noticed an increasing prevalence of childhood obesity. There was, an increasing prevalence of type 2 diabetes trickling in. We were receiving feedback from our providers, which is of extreme priority to us, and that kind of really, brought this to the top of our priority list. We kind of assessed our priorities also based on not only that feedback, but there was also a combination of research, there was competitive intelligence, and I would say, just common sense and feasibility, what is possible, what is not possible, but also, it was driven by gaps in care.
Mm-hmm.
And I can give you an example if you'd like.
Yes, that'd be great.
So, for instance, in 2005, the first thing we did was when we heard that when we realized that this was certainly something that we wanted to tackle, our first instinct was to reach out to our members. But we realized, given Medicaid members, we know that there's a lot of mobility, there's a lot of churn. Sometimes it's difficult to reach our members. Realizing that we're trying to reach children with young families, we thought maybe we should reach out to pediatric providers, given that probably they're more, some sort of a guaranteed contact point for families. So we thought we'd reach out to our providers, and we developed a childhood obesity physician toolkit for them and included a needs assessment. And I will say that more than 1,000 physicians faxed that survey back to us. This is way back in 2005, sharing very candidly that they were not comfortable, that they needed resources, including BMI training and some kind of education, because most of them never learned about childhood obesity in medical school.
Mm-hmm. Mm-hmm. It is the toolkit. And when I was reading about the program, I was kind of really interested in that. Is the toolkit actually a physical kit that a provider receives, or is it a set of protocols? Could you describe maybe a little bit more about what the toolkit is?
Sure, it is a physical toolkit that our physicians receive, and I personally don't like describing it as a toolkit because it includes so many things. It's like a compendium of resources. So it includes a number of physician resources. For example, we've included a childhood obesity CME, which is physician education that's been developed in partnership with the American Academy of Physician Medicine, that's the AAFP. It includes a physician reference guide, which has been developed in partnership with UCLA. It includes a BMI calculator wheel, CDC, BMI growth charts. There's a physician survey. And we also included parent educational materials so that physicians could use that resource, while providing care in the office. And physicians can order free copies using a fax back order form.
Wow. Very comprehensive.
Mm-hmm. It's been a great success, and the physician toolkit's been updated numerous times ever since.
Now, I also know that you provide BMI training to your providers. I think you partner with another organization to help facilitate that. Can you tell us how that works?
Sure, and that was a direct feedback to what our physicians needed. So the body mass index training is a multi-pronged effort. We have in-person training as well as online training. We partnered with the California State Child Health and Disability Prevention Program and provided free access to our physicians as well as their physicians and healthcare providers. And since, I think, 2006, we've implemented, I would say, more than 60 BMI workshops all over the country, and we've trained over 2,400 clinical staff, school nurses, and health educators in terms of how to use BMI to screen overweight and obese children.
Now, I'm sure that one of the drivers to making this initiative a priority was an expense or an expense-associated issue. And I know that healthcare expenses are nearly twice as high for an obese child covered under Medicaid than it is for a child under private insurance. Why is it twice as high?
That's a good question. I'm trying to think about how to answer that.
Is it because of a lifestyle situation with that population, or is it because they wait so long to deal with the issues?
Well, it could be a combination of both. Mm-hmm. It could be a combination of both. We know that most of the costs are shouldered, I would say, by our public programs, by Medicaid. Mm-hmm. And so I would say because there is a higher prevalence, probably children seek care when they're further along, mm-hmm. And therefore, the costs are higher.
Mm-hmm. I tried to find this study. I believe it was done by Yale University before the show, but I was unable to locate it. But I remember reading a study, I guess it's been 3 or 4 months ago, and I think it was done by Harvard or Yale. You may know what I'm talking about. that said this generation, our generation of children, because of obesity, may be the first generation that does not live as long as their parents live. Have you seen that by any chance?
Yes.
That was an astounding statement, I thought, when I read that. I mean, I knew childhood obesity was an issue, but I mean, something like that has got to be one of the drivers of moving this to the forefront and the focus at WellPoint, wouldn't you think?
Absolutely. I think our efforts, I will say this, that there has been a scarcity, a paucity of evidence-based programs to address childhood obesity. And I think the consensus is that prevention is probably the best treatment for childhood obesity, because as childhood obesity progresses, the costs that are associated with that are around the comorbidities. So that's hypertension, you're talking about type 2 diabetes, and those are lifetime chronic conditions.
Yes, yes.
So, when you think about something like childhood obesity, prevention is probably the best treatment.
Yeah, no question.
And that's what we're focusing on.
Yes, yeah, no question, no question. When this initiative, or when it was decided to focus on fighting childhood obesity, and there were, as you started to look at this, I'm sure there were a lot of different things that you could implement, a lot of different things that could be done to attack the issue. But what factors did you use to determine what the best course of action would be to take?
Sure. It was, we have a physician advisory committee. That was, it's a compilation of very diverse physicians in public and private practice. They have provided us guidance in terms of what efforts to implement, and they've kept us real. So that's certainly, one resource that we've turned to. The other is really, again, gaps in care. And the third piece of it is what's feasible. So again, just trying to figure out, do we focus on our members where we know there are going to be issues, trying to reach them, or do we first focus on our physicians and support them to ensure that they have all the resources and the training that they need to provide care to our members?
Mm-hmm. Yeah, no question, no question. Now, I know the initiative targeted children in the states of California, West Virginia, Virginia, Indiana, Kansas, South Carolina, Texas, and Wisconsin. Was there anything particular about those states, or that just a higher concentration for WellPoint of the Medicaid population?
So those are our states with Medicaid business.
Okay, all right. That's what I thought, but I didn't know. Maybe there was something unique about those states that we could explore in that. But I understand. Well, we're going to take another break here, just real quickly, and when we come back, we're going to hear from Dr. Sareen about some of the challenges that they had to overcome as they put this initiative together and begin to implement it and roll it out. So stay put. We'll be back in just a moment.
You're listening to Medicaid Matters on the blogtalkradio.com network. Are you a Medicaid industry expert, state executive, or thought leader? Can you share a perspective about the business of Medicaid that's unique, innovative, or even controversial? If so, you could be a future guest on Medicaid Matters. We are currently scheduling guests, and it's time to share your big idea about Medicaid. Go to our website.
Hey, Harvindeer, just real quick, while we're off the air, I just want to tell you you're doing a great job, so hang in there.
Thank you.
Okay. We're going back live now.
Okay.
Well, there's a lot going on in Medicaid today, no question about it. As you know, there's probably the biggest event we're waiting for is the end of June, when the Supreme Court announces their decision about the Affordable Care Act and its impact on Medicaid. But there's a lot of other things going on as well, and we're fortunate to have our friends from mostly Medicaid provide us with updates of what's new and different in the Medicaid industry. So here's a latest update from Mostly Medicaid.
Hi, this is Clay Ferris bringing you Mostly Medicaid news headlines from May 2012. Our first group of headlines deals with what we call new business. There's a lot of new wins announced in the Medicaid industry in the last 30 days, as well as a lot of new plans for RFPs. Highlights include that Centene wins really big in New Hampshire, being awarded a $2.3 billion Medicaid managed care contract. That contract spans 3 years with an optional 2-year extension. Also, down south, Georgia Medicaid is designing an RFP for managed care services for substance abuse and mental health. You might think the groups would be concerned about how they're going to cover the more disabled individuals under managed care, but the agency is having a mental health stakeholder group help shape the RFP. And then there's another group of topics we would call old business. So some of the new wins are squeezing out the existing contract. A good example of this, Molina is suing Missouri Medicaid because it limited the number of managed care contracts awarded this year. Molina, as you might guess, lost out in the recent bidding process and is not going to continue the contract for 430,000 members it currently covers. According to Missouri, limiting the number of players is going to save the state about $16 million. Another group of topics, a massive influx of federal dollars. Feds are sending $11 billion more dollars to increase pay to Medicaid physicians. Part of the health reform law requires Medicaid payments to various specialties to be aligned with Medicare payments. Also, Oregon got $1.9 billion from CMS to experiment with managed care for Medicaid mental health services. According to state estimates, the new model will pay for itself within 5 years and is going to start to reduce healthcare costs by 2 percentage points within 2 years. And our last group of headlines has to deal with fraud and lawsuits. McKesson's finally settled the federal lawsuit that charged they inflated the pricing data they gave to First Data Bank. McKesson's going to pay $119 million to be done with the suit. The U.S. Department of Justice is asking a court to force a Johnson & Johnson exec to testify in a Risperidone case. The case alleges J&J made illegal kickback payments to Omnicare. And finally, a New York State auditor's report still finds issues with the CSC eMedNey claims payment system. According to the report, the system paid $42 million incorrectly. For more information about these stories, job listings, and other industry analysis, check out moslymedicaid.com.
And we want to thank MostlyMedicaid.com. They've been a longtime sponsor of our show, and we want to thank them for providing those news updates. You can also be a sponsor of Medicaid Matters. It is not uncommon for several hundred people to be listening to this program every week, each of them interested in Medicaid and in your message. If you'd like to learn more about being a sponsor, you can either email us at info@medicaidservices.net, or you can call us at 615-257-1627. Also, don't forget to join our community on Facebook. When you like the Medicaid Talk page, you'll get updates, access to contests like the annual bonus that we gave away in January. You can watch the show live, and you can network with others in the Medicaid community. Point your browser to facebook.com/Medicaid Talk. Well, let's get back to Dr. Sareen now. And Dr. Sareen, I wanted to ask you, before we get into some of the challenges that you had to overcome to put this program, this initiative together and roll it out, how much time actually elapsed from when the problem was prioritized to when you started assessing solutions and then began implementing the initiative? Are you there? Well, we may have lost Dr. Sareen momentarily. We're going to work to get her back here in just a moment because we don't want to miss out on what she has to say about that issue. We're going to talk to you in just a moment. I think we're trying to get her back. Dr. Sareen, are you there yet? Okay. If you want to, we'll have her back in just a moment, I'm hoping, and we'll see what we can do to help get her back. Are you there, Dr. Sareen?
Your call cannot be completed as dialed. Please check the number and dial again, 138T.
Okay, apparently, as you can tell, we're having some technical difficulty getting her back on the line, but I'm sure she'll be with us here in just a moment.
Your call cannot be completed as dialed. Please check the number and dial again, 138T.
All right, for some reason the call has dropped off, so we're going to get back to her just as soon as we can. Hopefully we won't have that annoying information shared with us again on the air. If you want to learn more about this program, the one that we're talking with about to Dr. Sareen, and the 17 other programs that were nominated for the Best Practices Award, you can get all of that information in the Medicaid Health Plans of America's Centers for Best Practice Compendium. It's something that you can get right online, or you can certainly order it online from the Centers for Best Practices. And in here is not only the 17 programs that were nominated for the award, but also you can find programs that were nominated for many of the other awards that were part of the program, of the Centers for Best Practice Awards program. In total, there were 6 different awards that were given out. Some companies had multiple entries into it. Some were single entries. But every one of those programs, every one of those initiatives is included in this compendium, and you have an opportunity to read all about them. For instance, the initiative, the Childhood Obesity Initiative that we're talking to Dr. Sareen about, is in about 3 or 4 different pages in here in quite a bit of difficulty. And some of the things that I know she wanted to talk about, but we didn't have a chance to get to, is the different challenges that this particular program was trying to address. We did talk about how 1 in 3 low-income children are overweight or obese before their 5th birthday. Now, you think about that, before their 5th birthday, that's quite an astounding number. Minorities are particularly at risk, and childhood obesity has a significant short-term and long-term consequences. Also, these children are more likely to turn to Medicaid for their health care needs than perhaps any other type of program. Medicaid providers are in a bind because, of course, trying to do more with a whole lot less, and we can't sacrifice quality to do that. Medicaid and Medicare has paid for 1/2 of obesity-attributed medical expenditures in 2003, which I assume is the latest statistics. If rates continue to increase at their current levels, healthcare costs attributable to obesity are expected to be $344 billion by 2018. Now, that's an astounding figure, $344 billion just related to obesity-attributed illnesses and situations. It is a lifestyle. Well, I shouldn't. That's probably too much of a blanket statement. It can be a lifestyle choice, and I think that a program such as this, an initiative such as this, really partnering with providers and partnering with the members to help them through those lifestyle choices, to help them make behavior changes and so forth, are probably one of the best ways.
Your call cannot be completed as dialed.
Well, please
check the number and dial again. 138T.
Obviously, we're continuing to have some technical difficulties in connecting with Dr. Sareen, so we're going to keep doing that.
Your call cannot be completed as dialed. Please check the number and dial again.
So we're going to continue to try to get a hold of her. One of the wonderful parts of having a live program is you get to participate and share in a lot of the background things that are going on during the program. But in any event, this initiative, and one of the things we want to get to, hopefully that we can get her back, is to have her talk about some of the challenges as well as some of the results that they're getting from the program. If you'll just give me a second here, I'm getting a message from our producer. Apparently, it says she's on the line on hold. We're trying to bring her on the air right now, but we're not having a whole lot of success in getting her on the air. Linda, you're going to have to probably hang up and put her on. Probably going to have to hang up and put her on my screen. It's not showing that she's on the air. If you can bring her on, Linda, if you can go ahead and activate her line to go live, that might help if you want to give that a try. Because I'm not able to do it on my controls here.
Hello?
Hello, Dr. Sareen.
Yes.
All right, I don't know what happened.
You.
Good. I don't know what happened there, but boy, we were as close to a panic as we've ever been on the show.
Oh, no worries.
No, but you're back, and that's what counts, and we're glad that you're still with us and part of the show. I was trying to explain some of the challenges while we were waiting for you to get reacquired. Some of the challenges that that you were facing as you put this initiative together, but I wanted to talk about some of the challenges that you came up against as you began to roll this out. For instance, anything with this scope of responsibility. I mean, multiple states, multiple pieces working together, all of these things coming into account. What kind of challenges did you encounter as you started to implement this initiative?
Multiple challenges. I can summarize some of them for you. I think one of the things that really took us by surprise was the lack of benchmark for standardized care for screening in physician's office. So that was really a surprise. Another one was the time that it took to get legal and regulatory review for, in multiple states. That certainly put in a time factor for rolling out an initiative across multiple states. As you can imagine, evaluation was a struggle for many of our initiatives. Just trying to collect data on BMI, data from our providers, data directly from our members is certainly a challenge. And then lastly, I would say that just finding evidence-based weight management programs, that really work in the real world, that have great uptake, that have sustainable results, and that can be scalable is certainly a current challenge at this time.
Now that does surprise me because if you watch any, let's just say television, you watch television for any length of time, you're going to get all kinds of information about weight management and losing weight and so forth. So not having any kind of evidence-based programs that you were able to utilize, that's really surprising to me.
For children, there are a number of evidence-based programs, but most of them have been conducted by academic centers, and so very few have been tested out in the real world. So some of the things that you see on TV are targeted at adults,
right?
And they've not been scaled to children, and we don't know if there's an evidence base for those in terms of how they'll work for children.
That's true. Good point. Did you, the different challenges that you dealt with, were there any that you anticipated? And you'd mentioned, the lack of any kind of benchmark is one that surprised you. Were there any others that surprised you?
Not surprised. I think we struggle with the lack of evidence-based programs, but I think that the lack of, the benchmark was the one that really surprised us.
Tell me about that a little bit, because I'm like you. I'm surprised too. I mean, we hear a lot about BMI and what it should be at different ages, and maybe I'm just again thinking about adult references. There's been nothing like that for children, or is that the wrong benchmark I should be thinking about?
The body mass index is certainly the right, the recommended benchmark, certainly by the CDC, by the American Academy of Physicians, American Academy of Pediatrics, AAP, a number of other organizations as well. It's just that for children, you calculate the BMI, and then you calculate the BMI percentiles, which makes it specific to the child based on gender as well as age. It's just that when we rolled out the initiative in 2005, there were no recommendations, no standard screening. And so when we were charged with trying to assess the scope of the problem, there was no way of doing that if, a few physicians, let's say in 2005, 2006, less than 5% of our physicians were in California, as an example, were really using using BMI to screen children for overweight and obesity. So how do you really assess, what the scope of the problem is? And are children receiving the kind of care that they can get? And I think it was because obesity is a relatively new epidemic. A number of physicians have not learned about obesity when they went to medical school.
Mm-hmm.
There were no standardized guidelines as such at that time.
Mm-hmm.
And so that's the reason why there was a lack of a benchmark.
Interesting. How did the provider community react when you started to initiate this program?
Well, the reaction from them came from, a place where they wanted to learn. Mm-hmm. They wanted to become more comfortable in engaging these families in preventing childhood obesity. I think they were very candid in expressing, the desire to have more knowledge. They wanted to have the resources. As I mentioned, this was not an area of expertise that they acquired when they went to medical school. Mm-hmm. So we've certainly responded to that, that request. I think at this time, the reaction from the provider community is that we're conducting these screenings, we're identifying children who are at risk or overweight. What are the evidence-based weight management programs that are out in the community or elsewhere that we can refer these children to?
What kind of challenges did you face in getting members to comply or participate in the initiative?
I will say this, that our goal has never been compliance. Okay. I'm sure you'll agree that there's no magic bullet or magic pill. And so it's our initiative is more around supporting our physicians, through primary care. The way we've couched it is we empower our members with the information and resources that they need to live a healthier lifestyle. Mm-hmm. So what we're seeing is we're seeing definite improvements among our physicians in terms of screening and identifying children. In terms of our members, we're trying to learn more. For instance, I'll give you an example. We brought innovation to our California CHIP program by including a benefit design with including nutritional counseling, which really indicates our commitment to finding, the next step. This is a resource for our physicians as well as our members. But at this time, we're tracking uptake and really trying to understand some of the barriers that our physicians as well as our members experience, which may prevent them from really leveraging this benefit in a very optimal way.
Wow, great. Now, how was technology used to support this initiative?
In a number of ways. I think we certainly have a vested interest and commitment to leveraging technology. In an operational way, we're supporting, encouraging providers to include BMI and BMI percentile in their EMRs. But in a more fun and exciting way, we're certainly leveraging it to promote physical activity, for example. And I think you mentioned this before. We implemented a pilot to promote extra gaming in California with the Boys and Girls Club of Camarillo. So extra gaming is really, any effort that it's kind of an interactive video game effort that incorporates exercise in a way that promotes inclusion and appeals to all levels of skill and body types. Mm-hmm. So it's are you familiar with the Connect?
Oh yes. Mm-hmm.
So that's what it is. It's really leveraging the Connect to promote physical activity.
It's that same technology, the Xbox Connect technology.
Yes.
Wow. So how
and so go ahead.
I was just curious, how does that work? Are you delivering them to community resources or to members? How does that work?
Well, we wanted to understand if it was really effective and understand the nuances involved with leveraging the Connect for extra gaming. And we piloted it with the Boys and Girls Club, and the preliminary results show that it does increase physical activity among these children of different ages. And it also tends to engage those kids who are less athletic. Mm-hmm. So our goal is to really try to use this technology in situations or areas where there are a number of children. So a number, to kind of leverage the maximum benefit. Mm-hmm. And we're definitely in discussion to expand this initiative.
Wow, now that's pretty exciting. I mean, I think that's pretty interesting how you can take, you didn't have to come up with something necessarily as a new technology platform, but leveraging something that's available in the commercial market into this, and something I'm sure the membership is familiar with. Mm-hmm. Very interesting. Well, as you look back on the initiative and kind of what you went through to get to this point today, is there anything you would want to do differently or restart in a different way?
That is such a difficult question.
That's my job.
That's a difficult question to answer because I think what we've done is really address challenges as they came along and address needs as they were expressed.
Mm-hmm.
So I'm not sure if we could have done things differently.
Mm-hmm. Okay.
Yeah.
Well, that's certainly a fair answer. Obviously, this program has had a great measure of success. It won an award, and this isn't the Innovations Award was not the only award that this initiative has won. Tell us, in a little more detail, some of the results in health improvement that your members might be seeing as a result of this initiative.
Sure, and here's what we know. So we have a number of providers, as I mentioned. We're tracking results for our, among our providers, our members, as well as our communities. So in terms of our providers, we're seeing more and more of our providers, our doctors, use BMI to screen for overweight and obesity. We see that through an increase in our HEDIS scores. So as an example, in 2006, I'd mentioned that less than 5% of, taking California as an example, less than 5% of our Medicaid providers were using BMI to record and observe and record children. But now that, I can say that now our HEDIS scores are as high as 66% in some counties in California. Mm-hmm. Another result is we know that many of them are reaching out to participate in our CME, our continuing medical education on childhood obesity, which is indicative from their participation on the CME. The requests for the toolkits keep pouring in. We know that they're making use of our resources. We know that they are distributing our resources to our members. Mm-hmm. And we know that these efforts will definitely lead to an improvement in our member health. Mm-hmm. In terms of our members, we're understanding what really works for our members. We've certainly launched a number of innovative efforts. I mentioned the CHIP effort. We just recently launched a very innovative adult obesity effort as well. We're expanding in that area and trying to learn, what do members respond to. And we've learned, for instance, the effort was an automated voice technology, healthier lifestyle message that was sent to all our Medicaid states. And just preliminary results show that out of the 2,751 members we've reached so far, more than 1,000 members have requested the simple incentive that we've included in the initiative, which is more than 37%.
Yeah, that's great. No question about it. Well, we have a caller who wants to ask you a question as it relates to accountable care organizations, and her name is Sharish. I hope I pronounced that correctly. Linda, go ahead and... Well, I'm hearing she has moved on. She wasn't able to stay on the line, so we'll move on with our questions then. Now, how has this program or this initiative caused other points of WellPoint to incorporate some of the concepts, some of its operations into their different priorities?
Well, the issue of childhood obesity remains very important to WellPoint. So, although many of these initiatives have been born out of Medicaid, the Medicaid part of our company, they have been scaled and replicated across our commercial brand in 14 states. Mm-hmm. So, for example, the physician toolkit that I mentioned has been made available to all our physicians across 14 states. Okay.
What are you seeing in terms of overall cost savings as a result of the initiative?
Well, that's always a challenge. Mm-hmm. I think cost savings are a long-term measure, especially when it comes to childhood obesity. I think cost savings are something that you see over the life of the, lifetime of the child.
Mm-hmm. Has there been? Go ahead. I'm sorry.
I was going to say that our results are more in terms of quality, mm-hmm. quality measures, participation than revenue.
Tell us a little bit about that then. What kind of quality changes are you seeing in those measures?
Well, we're seeing improvement in HEDIS. As I mentioned, we certainly participated. We were probably one of 3 plans to work with NCQA to see if assess the feasibility of a performance measure for childhood obesity. NCQA did announce childhood obesity HEDIS measures. We're tracking those HEDIS measures. We see an improvement. We're also looking at our CAPS measures, and we're noticing an improvement in terms of our members talking about the care that they're receiving as well. We're definitely seeing improvement in provider training, education, participation as well. So those are some of the outcomes that we're tracking.
Great. Well, remind our audience, our listeners and our viewers, how long has this initiative been in place?
We started in 2005 with a childhood obesity physician toolkit.
Okay. So in that time, I'm sure the program has undergone fine-tuning, as every program, as every initiative does. What do you see as kind of the next evolution for this?
So the next evolution would be, certainly trying to understand how can we reach out to adults to really kind of see if there are best practices among the childhood obesity interventions and focus on adults. I think another part of our efforts is going to be focused on understanding benefits and trying to really pinpoint what works and what doesn't work.
Mm-hmm.
We're certainly focused on the evidence base and leveraging technology and expanding our efforts. And lastly, I'm going to throw this in there, we're also exploring home visits to find effective solutions, yes.
Mm-hmm. Is that something that's kind of on the drawing board, or is that just kind of in the exploration stage right now?
It's on the drawing board.
Okay. All right. Well, there's one other thing I wanted to ask you about, and I had planned to ask you when we were having the technical difficulties and we weren't connecting, so if it seems a little out of place in our conversation, that's why. One of the things that you had talked about early was keeping a focus on the life course perspective and health across the continuum. Explain to our viewers what you mean by life course. That's not a term that I'm real familiar with.
Well, and I'm not an expert on that, but what I meant by that was, sometimes what we do is we tend to focus on different phases. So, for example, in prenatal care, there's a tendency to focus on prenatal care per se when a woman is receiving prenatal care, but the life course perspective would advocate that you focus on the health of the woman before she gets pregnant,
mm-hmm.
while she's pregnant, and after she has the baby.
I see.
So that would be the life course perspective.
And how would that relate to obesity?
So in obesity, we know, for instance, breastfeeding is probably one of the few evidence-based strategies to prevent childhood obesity. And so we want, our goal would be that, especially Medicaid women, I'm sure you'll agree that Medicaid, there's a high prevalence of poor birth outcomes among
mm-hmm.
Medicaid women.
Yes.
And so in order to improve those birth outcomes, to encourage breastfeeding, and in that, in that way really promote the prevention of childhood obesity, we want to ensure that they have all the care that they need, which would mean improving the receipt of prenatal care. But if we were to follow the life course perspective, it would mean ensuring that they receive the care that they need even before they receive prenatal care.
Very good. Well, I think our listeners and our viewers can see why this initiative won the Innovations Award. I want to say thank you so much for being with us today and for bearing through our technical difficulties. We apologize for that, but it's one of the
90 seconds
about doing a live show is that you get to deal with those as well.
No worries. It was my pleasure.
Good. Well, if any of our listeners or viewers have any comments or reactions to today's show, you can send them to me at MedicaidTalk.com. I read all of them. Certainly appreciate any constructive feedback that you care to share. Our next show is going to be on May 29th, and believe it or not, that will be our one-year anniversary show. I'm sure we'll have a few surprises, so mark your calendars to join us then. And don't forget to go to MedicaidTalk.com and register to receive a complimentary access to one of the Medicaid Health Plans of America's Centers for Best Practice webinar. It's a $150 value. All you have to do is sign up for our blog and we'll have a drawing for this award on that May 29th show. I appreciate you being with us here today. This is your host, Richard Gaden. Today is Tuesday, May 15th, 2012. You've been listening to Medicaid Matters, brought to you by Managed Medicaid Services. I hope you have a great week, and we'll see you on May 29th.
Ten seconds.